Hello, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we are thrilled to have a world-renowned hematologist join us, Dr. Vincent Rajkumar from the Mayo Clinic. If you treat MGUS, smoldering myeloma, or multiple myeloma, you've come across his work. Though multiple myeloma is only 1% of all malignancies, as community hematologist oncologists, we see a lot more MGUS and smoldering myeloma. Today, we'll have Dr. Rajkumar walk us through his treatment algorithm regarding these common findings in our clinic. Let us get started. Dr. Rajkumar, welcome.
Thanks so much for having me.
Dr. Rajkumar, thank you for joining us today. Let us get started by focusing on MGUS to start off. Dr. Rajkumar, what is MGUS and how prevalent is this?
So MGUS, the expansion is monoclonal gammopathy of undetermined significance. It is a term that was coined by Dr. Kyle, who's a well-known hematologist at the Mayo Clinic. This refers to a pre-malignant plasma cell disorder. And it is present in, I would say, approximately 5% of the general population over the age of 50.
Yeah, thank you for just going over or laying that foundation. I think it's essential from our perspective to reiterate that these patients are asymptomatic and are often diagnosed with MGUS as an incidental finding. Let us dive in a little deeper. Dr. Rajkumar, how do we categorize patients that are low risk versus everything else, and why is that important? How is that dictating your workup?
So MGUS is asymptomatic, and generally we find it because we are thinking maybe the patient has multiple myeloma, amyloidosis, or some other plasma cell disorder, and we work them up. We find a different diagnosis that explains their symptoms, and then we are left with a monoclonal protein. That is the most common scenario. But as protein electrophoresis is being done so frequently, almost like a SED rate, we are finding more and more patients getting diagnosed with a monoclonal gammopathy who don't have myeloma, amyloidosis, or any other problem. Same way, the serum free light chain is also being done so frequently. And you are going to end up with a lot of patients having abnormalities detected, even though they don't have any symptoms of concerns of amyloid or MGUS. I also feel it's important that we don't burden the clinician with extra tests. So the risk stratification basically uses laboratory tests you already have, which is the size of the monoclonal protein in grams per deciliter, the type of the monoclonal protein, whether it's IgG or IgA or IgM, and the free light chain ratio. And using this, you can classify patients into low, intermediate, and high risk.
Thanks for mentioning that stratification, Dr. Rajkumar. Whenever as community oncologists, our workup initially gets started by sometimes PCP or nephrologists when they see slight elevation in creatinine. And now when we obtain, whether it's IgA or IgM, where mild M spike is present, following the algorithm, one would be sort of hesitant to order bone marrow biopsy when there is only very mild M spike present, or even PET CT or further imaging. Is that what you do, or how would you stratify such a situation?
So when you have a patient with a low risk MGUS, that means you had a small monoclonal protein less than 1.5 grams. It's IgG kappa or IgG lambda. And then the serum free light chain ratio is normal or close to normal. That's half the MGUSs. Even then, I don't automatically say this is low risk and ignore it. The key in the algorithm is it has to be uncomplicated. There should be no other red flags. If somebody is worried because the patient has an unexplained anemia or unexplained lytic lesion, I take those very seriously, or unexplained renal function abnormalities or glomerulonephritis. Then it's no longer just a small monoclonal gammopathy. It's a small monoclonal gammopathy with a potential significance. And therefore, in those patients, I take it more seriously and decide to do workup. So in our algorithm, when we say in low-risk MGUS, you can just omit the marrow, omit the bone survey, and just recheck in 6 months. That's only for patients where there are no other red flags. Whatever reason you ordered the M spike, you already have an answer to, and you're no longer worried about a major plasma cell disorder. That's the patient you can say, this is a coincidental, incidental finding. We can reassure you. Let's just recheck in 6 months, and if it's okay, we'll leave you alone.
Makes sense.
But
Thank you.
Dr. Rajkumar, here we're talking about one half that is low risk. But let's say IgA, there is a little spike, but we're not seeing anything else. And these are the patients that end up with us. In the IgA spike, technically they fall in this all other patients category. Would you be aggressive if you don't have anemia or a significant renal dysfunction and this was checked by your neurologist for neuropathy? So how aggressive are you in those scenarios for these patients for a bone marrow biopsy or imaging?
So excellent question. See, when we first decided to do this algorithm, it was like really a struggle. When we first provided the consensus opinion, we went with a rather conservative, like at least let's not subject the low risk MGUS patients to a bone marrow biopsy and a bone survey. I've started expanding this because I feel otherwise we're going to unnecessarily put even a lot more patients also. So I've expanded this to small IgM MGUSs, less than 1.5 grams, that you really don't need to worry about those, similar to low risk MGUS. Expanded that to light chain MGUS, where if the ratio is less than 8 involved over uninvolved, that's most of the abnormalities people find. You can just consider that as a low risk MGUS. And I'd like to expand that also to IgA. If the IgA is small, particularly less than a gram, I would be more comfortable. The problem with IgA is you have to be careful that you don't rely only on the M spike because of the IgA tends to dimerize or trimerize. So you want to make sure you check the IgA level also and make sure it correlates with the M spike.
And before we move on to the next stage, in your clinic, a patient with low risk MGUS, how often do you recommend these patients should be followed with a hematologist?
Yeah, and I'll just go through the whole algorithm itself so
That'd
that
be
your
perfect.
listener is really crystal clear. Someone is referred to you with a monoclonal protein or an abnormal light chain ratio. You look at the M spike size, the type, and the free light chain ratio. A small M spike less than 1.5 grams with a normal or relatively normal light chain ratio, and it's IgG type or IgM type, you can omit the bone marrow if there are no other red flags. You can omit the bone survey and basically repeat these tests in 6 months. If they are stable, you can actually reassure them and say that the lifetime risk of progression is only 2%, not even 1% per year, but more like 0.1% per year. And if there is a symptom, we can recheck you. Otherwise, you can be reassured. There are some people who would say, let's see them at least every 3-4 years. I'm okay with that. All other patients, I would say recheck in 6 months and then once a year thereafter. At baseline, get a bone marrow and a bone survey just to make sure that you're not missing myeloma. You don't need a bone survey if it's an IgM MGUS, unless there's some other reason to. But other non-low risk MGUSs, you would get a bone survey as well to make sure that there is no lytic lesion or myeloma at the baseline. So even if you don't think there is, it's a good baseline so that in the future, if the patient has a problem, you have a benchmark to go back to and say, no, that small little lesion was there at the baseline, don't worry. And I found it to be very useful to get it in these kind of patients.
Absolutely. Thank you. That was very, very helpful.
Thank you. And when you talk about the skeletal survey, I know PET-CT is being utilized as a more recent modality. Is that what you refer to, or even bone skeletal survey using X-ray?
We generally prefer a CT survey, a low-dose CT survey. That's what I would recommend. It's 10 minutes. It's very low radiation exposure. You get a very good resolution of the bones and a good baseline for future. Always helped me. The problem has been that some institutions don't have low-dose whole body CT as a billable entity. and insurances sometimes hesitate to cover. So some places use a PET CT instead, and there they're using the CT portion of the PET scan to have a low-dose CT image of the bones. Either one is okay. If they are not available, then of course you can do a skeletal survey.
Again, thank you for covering that component. As this disease progresses, this is where we run into something like smoldering myeloma. Dr. Rajkumar, how do we define smoldering myeloma, and how common is it for us to find patients in this stage?
Yeah, and I think, this, without historical context, people get it so confused, and it's worthwhile getting the historical context. Dr. Kyle, who just turned 95, has been my mentor for decades now. And just being with him and understanding his thought process and how this happened is very, very useful for people to understand. In plasma cell disorders, we have a unique situation where, unlike other cancers where the pathologist simply tells you this is carcinoma and you take it without asking any questions. You just say, okay, carcinoma, I'm going to treat it like colon cancer or breast cancer. Whereas in plasma cell malignancies, the pathologist is unable to say that, regardless of the plasma cell percentage. So they just say clonal plasma cell disorder. And we have to use clinical tools to decide whether this is possibly a malignancy or a pre-malignancy. So early on, when there were these patients with monoclonal proteins and there's no other symptoms, Dr. Waldenstrom called it benign monoclonal gammopathy to separate it from myeloma and Waldenstrom's. Whereas Dr. Kyle felt that as he followed these patients, that a small number each year was getting myeloma. And he didn't want to call it benign because he wasn't sure it's benign. So he called it monoclonal gammopathy of undetermined significance. And he arbitrarily said less than 10%, less than 3 grams, no symptoms, I'll call it MGUS. And that was all fine till from 1960s, late 60s to the 1980s, when he found there were patients with more than 10% plasma cells and more than 3 grams M spike without symptoms that he basically watched. And he found some of them never progressed. So he and Dr. Greip wrote an article in the New England Journal saying, we don't know where to put this. We'll call it smoldering multiple myeloma. It's an in-between entity. And for many years, again, people have thought smoldering myeloma is a pre-malignancy. So it's like MGUS, don't treat unless the patient's getting malignancy. Without recognizing this is an arbitrary clinically defined tool where we have no idea who's got malignancy, who doesn't. We don't want to make either mistake. We don't want to reassure a patient with malignancy and wait till they get problems. We don't want to intervene early in somebody who's got a polyp like pre-malignancy and then have all the complications of second treatment. So it was easy in the 80s, 90s when the melphalan was the only treatment and transplant, and they said, we won't treat unless we see something. So we'll watch. And they estimated, and I was the last author on the paper, where we found that 10% per year of patients progress to multiple myeloma over the first 5 years. Then it drops to 3% per year and then to 1% per year. And that was in the New England Journal of Medicine. Later on, many of us felt that the way the curve went, it looked like we were actually dealing with two separate populations, heterogeneous group of people who we were calling smoldering multiple myeloma. Some had malignancy and will declare themselves in the next 2 or 3 years, and some had pre-malignancy and would have a progression rate just like 1% per year. So once we recognized that, the idea was we don't want to wait for the end organ damage to occur. And that's where we started looking at, can we identify the patients who would progress faster? The first step of that was simply, let's identify the really, really high-risk patients who are going to progress within a few months, and it's a mistake to call them as pre-malignant. And that's what we found, when the plasma cell percentage was more than 60%, the outcome was not good. It was not like 10% per year, it was 40% per year. So we took out the small slice of smoldering myeloma that had a very rapid risk of progression. But that's only 5-10% of smolders. So the vast majority are still there. And more recently, we have found that you can, just like with MGUS, you can split them into two groups, those who are low risk and those who are high risk. The high risk comprises of only about a third of all patients with smoldering. And if you take that group and you follow them, 25% will progress in the first year and another 25% in the second year. So that's 50% risk of progression in 2 years. The remaining patients have a much lower risk, probably 5% or less per year of progression.
Thanks for going with the background. That really puts things in perspective. Dr. Rajkumar, there has been a lot of debate about who exactly should be treated. And as you suggested, that high risk is something that should be. Is that how you proceed with the algorithm where you utilize lenalidomide or RD regimen?
Yes, and so what we've done is, like, there are many ways of defining who has high risk smoldering myeloma, and this is also good for listeners to know. When I could come up with the most sophisticated genomic prediction tools with all of the things that only two institutions can do. That doesn't help the vast majority of the world. We want to use tests that everyone can risk stratify and use tomorrow in the clinic. 10 years from now, if we can tell genomics and be able to predict, that's okay. That's the first point. The second point is no test is perfect. You can never be right. All adjuvant therapy assumes, like, if you take breast cancer and you give adjuvant therapy, 80% of those patients probably don't need adjuvant therapy, but we are doing it so that the 10-year survival rate goes from 80% to 90%. That means you are over-treating some, but that's the price we are willing to pay to make sure we have a better survival for the whole cohort. So that's the second thing, is like no test is perfect. So what we found is simply using the M spike size, 2 grams or more than 2 grams, bone marrow plasma cell involvement more than 20%, and light chain ratio more than 20. If patients have any two of the three, we find it, if you take any group, and we've done it at Mayo, we've done it in other cohorts in the IMWG, about 50% will progress within 2 years. That's the group we call high risk. And then we look at the randomized trials that were done, the Spanish trial and the ECOG trial, in terms of what happened to these patients. It was the outcome in the observation arm paralleled what we would expect. In the treatment arm, the risk of progression was relative risk-wise 90% lower. So we feel like, given that, number one, we don't think these patients have pre-malignancy. This is malignancy, it just hasn't declared itself, that we are willing to intervene. Secondly, the intervention itself didn't cause harm. We know that you can take myeloma patients over the age of 70 and give not just Lendex, but Dara-Lendex, and the 5-year, 10-year survival is really great. In the ECOG trial, only 2 patients in the lenalidomide arm have died, and 4 in the observation arm. So the treatment's not like life-threatening, but the risk of end organ damage is reduced sharply by 90%. So we feel like we are willing to treat these patients in order to prevent end organ damage with 2 of the trials that have been done with these agents providing it. And we don't want to give endless therapy, so we limit it to 2 years, which is the period that patients in these trials actually took the treatment. All other patients, that's 2/3 of smoldering, I would just watch them or enroll them on clinical trials.
Dr. Rajkumar, thank you so much for going over that, because that is a discussion we often have back and forth with the patient. What is the benefit? And again, just to push you a little more on this,
Sure.
When they're being treated for high-risk smoldering myeloma, so do you share that with your patients that in this scenario, we're hoping that we're going to delay the end organ damage? Are they being cured? Are we seeing these patients are living longer with this intervention? What is the end overall benefit when you're having that discussion face-to-face with your patients?
Yes, excellent question. So first of all, when we use Len or Lendex, we are not trying to cure the disease. We are trying to do early therapy to delay progression, to delay the inevitable, hopefully. Hopefully we can prevent patients, because many of them are elderly and they'll have some other problem. And I have to go with the Spanish trial, which has much longer follow-up, and they do have a survival difference. And so we say one of the 2 trials shows a survival benefit. Both trials shows a reduction in end organ damage. We don't think this treatment is curative, but it will prevent, likely delay or prevent end organ damage. And many of us wouldn't want that end organ damage, particularly if it's renal failure or bone lesions.
Now, catching on to that point of bisphosphonate or bone modifying agents, now we utilize them in myeloma setting. Any role of utilizing them with lenalidomide or Lendex while they're being treated for high-risk smoldering myeloma?
You know, the great question. And if you read some of the papers I've written, I have no idea. Even I'm confused because the trials are both ways. There's very small trials, very little information. I usually don't recommend it. What I do recommend is something like osteoporosis-like treatment, once a year of pamidronate or zoledronic acid, which I feel I could recommend even for a patient with MGUS who's elderly. But I don't want to go beyond that. I also want to address this other question that you've given, at least so that you have a frame of reference for how we think. So as an investigator, you're always struggling with, okay, for the immediate, I want to delay progression. I want to prevent end organ damage. Something better than that, it'll be great if I can prolong overall survival. I might actually have it. I just don't have the numbers to prove it. Okay, that's the setup we think we are in. But I also think that, hey, what if smoldering myeloma what if myeloma is not curable only because we are starting the treatment too late? That's a hypothesis. What if myeloma is actually a curable disease, but because we arbitrarily 20, 30 years ago defined myeloma as a cancer only if we see lytic lesions, not like breast cancer or colon when the pathologist tells you it's carcinoma. Maybe that's why we're not curing this disease. If we only treated smolderers, then maybe we will get cures.
And certainly a thought-provoking point, especially when we're talking about so many approvals in myeloma. This daunting task of myeloma still being incurative is certainly concerning. Well, we have covered one of the most common referral topics we see as a general hematologist oncologist. To recap, it is essential to categorize MGUS patients based on their risk progression and put a full picture together, as this will dictate the workup and how closely the patient needs to be followed up. A detailed discussion with the patient on pros and cons of treating the high-risk smoldering myeloma is critical. Dr.
Yep.
Rajkumar, thank you so much for discussing these clinically relevant algorithms and treatment with us today.
Thanks so much for having. It was really enjoyable and look forward to speaking to you again.